Bismillahirrahmanirrahim. This video describes the pathophysiology of diabetes mellitus. Diabetes mellitus is a syndrome that is characterized by impaired carbohydrate, fat, and protein metabolism that is caused by either lack of insulin secretion or decreased sensitivity of the tissue to insulin. So, these can be termed as type 1 diabetes mellitus and type 2 diabetes mellitus. So the type 1 is due to lack of insulin secretion, and then this type 2 is due to decreased sensitivity of the target tissue to metabolic effect of insulin, that is also termed as insulin resistance. So in type 1 there is little or no insulin secretion from the pancreas, usually results from autoimmune destruction of the beta cells in the islets of Langerhans, and patients require insulin therapy to survive. While in type 2 diabetes, that is insulin dependent, here in type 2 diabetes there is sensitivity of the target tissue to insulin is decreased, and initially insulin may be secreted normally and even at high level, but tissue response is impaired. This is often linked to obesity, sedentary lifestyle, and various genetic factors. What it does, it prevents the efficient uptake and utilization of glucose by most of the cells of the body. So the impaired uptake and utilization by most cells, but you remember there is one exception, that is brain, and this will result in hyperglycemia, that is high blood glucose level. Then there is also increased breakdown of the fat due to lack of insulin action, and this can lead to ketosis and acidosis in severe cases. And also there is effect on protein metabolism, where the increased catabolism of the protein lead to muscle wasting and weakness. Deficiency of insulin production due to damage or destruction of the beta cells in the pancreas leads to type 1 diabetes mellitus. The contributing factors are autoimmune disorders, where the immune system is attacked by beta cells. There are viral infections that trigger immune mediated destruction, and there is also hereditary predisposition to the beta cell degeneration. This affects about 5% of the patients with diabetes mellitus. It commonly begins at the age of 14 years, hence it is termed as juvenile diabetes mellitus, but it can also occur in adults due to pancreatic damage. Typically has an abrupt onset. Symptom develops within days or weeks. The key pathologic effects are increased blood glucose, that is hyperglycemia. Then there is enhanced fat breakdown for energy and increased cholesterol formation by the liver. Then there is protein depletion due to increased catabolism of the protein. Blood glucose concentration rises to a high level in diabetes mellitus. The peripheral tissue has got decreased efficiency for the utilization of the glucose. Normally, the 80 to 120 milligram per 100 ml, that is the normal range of the blood glucose. In the disease, it can rise up to 300 to 1200 milligram per 100 ml, and this is due to increased glucose production by the liver by the process of gluconeogenesis and glycogenolysis. So, increased blood glucose will lead to increased loss of glucose in the urine. Normally, the kidney reabsorb glucose up to a certain limit, and when blood glucose level exceeds 180 milligram per 100 ml, that is the renal threshold, the excess glucose begins to spill into the urine, and the term is called as glycosuria. The, the above 180 milligram per 100 ml, the renal threshold, at 300 to 500 milligram per 100 ml blood glucose, the urinary loss of the sugar is about 100 gram per day. So this leads to energy loss since glucose is being wasted rather than used by the body. Severe hyperglycemia will exert osmotic effect. In untreated diabetes, the glucose level can rise up to 8 to 10 times of the normal, and glucose remains largely in the extracellular fluid as it cannot freely cross the cell membrane without insulin. This increases extracellular fluid osmotic pressure, pulling the water out of the cell, resulting in intracellular dehydration. So, osmotic diuresis also occur. Excess glucose is then secreted in the urine, glycosuria, the term we have already discussed, and the glucose in the renal tubule, they create an osmotic effect, reducing the fluid reabsorption, and this leads to polyuria, that is excessive urine output, and further loss of body fluid and electrolytes. So extracellular dehydration from the blood or fluid loss in the urine occurs. This will result in intracellular dehydration as water shifts out of the cell to balance the osmotic gradients. Then there is increased thirst or polydipsia, that is the compensatory mechanism to restore the fluid balance. There is vascular damage due to chronic high glucose concentration. The long-term uncontrolled hyperglycemia damages blood vessel, leading to atherosclerosis, that is thickening and narrowing of the artery, and there is reduced blood supply to the vital organ and tissues. The major complications occur: heart attack, myocardial infarction, stroke or cerebrovascular accident, and stage kidney disease, that is diabetic nephropathy, retinopathy, and blindness due to damage to the eye blood vessel. There is also ischemia and gangrene to the limbs due to poor circulation, and then there is occurrence of peripheral neuropathy. Uh, there is impaired sensation, especially in feet and hands, increased risk of injury and infection that lead to ulceration, and in autonomic nervous system dysfunction also occur. So there are impaired cardiovascular reflexes, bladder control problem, abnormal sweating, and digestive issues, and then protein damage due to glycation uh, or glucose binding to the protein. They are damaged and results in endothelial cell dysfunction that may be due to metabolic stress. Then hypertension occurs also second to the kidney damage, and there is abnormal lipid metabolism that results in atherosclerosis. So both worsen the vascular damage. So in diabetes or lack of insulin, there is shift of metabolism, and this shift is from carbohydrate metabolism to fat metabolism. So now cell begins to rely on fat metabolism for energy, leading to increased breakdown of fatty acid, and as a result there is increased production of acetoacetic acid and beta hydroxybutyric acid. This is termed as ketonemia, that is elevated ketone in the blood, and as a result the metabolic acidosis develop because these keto acids they accumulate faster than they can be oxidized. This lead to diabetic ketoacidosis combined with the dehydration. There is severe this dehydration we have discussed is due to osmotic diuresis, and then both these effects can produce severe acidosis and diabetic coma, and if left untreated it will result in death. So there are some compensatory mechanisms for this. There is deep and rapid breathing process as a physiological compensation. This is the Kussmaul breathing or Kussmaul respiration. There is increased carbon dioxide expiration to reduce the acidity. However, this also depletes the extracellular bicarbonate stores. Then there is a compensation by the kidney, where the kidney they reduce the excretion of bicarbonate, and also they increase the formation or generation of new bicarbonate to buffer the blood. Then this severe acidosis, during this severe acidosis and coma, when the blood pH level goes below 7, this diabetic coma can occur. So without immediate insulin treatment, that may follow within hours. So there are some long-term effects of excess fat utilization. These are increased cholesterol synthesis. This leads to hypercholesterolemia, increased formation of the cholesterol that results in arteriosclerosis and further damage to the vessels, compounding the damage of the diabetes. This image is a bar chart comparison that shows the differences in blood parameters between a normal individual, the purple bars, and a person with the severe diabetic ketoacidosis, that is red bar. So what are the key observations? Glucose in the normal is about 100 milligram per deciliter, while it is it has touched in diabetes about 400 plus. This is significant rise in blood glucose in diabetes. Then there is keto acids that are normally 1 milliequivalent per liter. They are present in the blood, but in diabetes they go up to 30 milliequivalent and show excessive ketone bodies production leading to ketoacidosis. Total cation that are normally 155 milliequivalent, they decrease to 130. in diabetes. Reduction in cation concentration is due to metabolic imbalance and dehydration. Then there is bicarbonate ion. This bicarbonate is normally 27 and it has decreased to 5 milliequivalent. Drastic drop is due to buffering of the acids due to in the condition of acidosis. Then chloride that are normally 103, they decrease to 90 milliequivalent, and this slight decrease is due to shift in electrolyte balance. The pH is normal, pH is about 7.4, but in severe diabetic ketoacidosis it goes below 7. Then cholesterol, that is normal level of the cholesterol is 180 milligram per deciliter. In these conditions, diabetic condition, this level may doubles. So hypercholesterolemia is due to excessive fat breakdown. So key points are that this glucose is not used as energy substrate effectively due to deficiency of insulin or resistance of the insulin, and cell cannot uptake glucose efficiently, leading to energy crisis. So in this crisis there is increased utilization of the protein and fat as the body shifts to using protein and fat as alternate energy source. Muscle protein are broken down into amino acid which are then used for gluconeogenesis, that is production of glucose in the liver. The protein store is reduced, and due to lack of insulin, the synthesis of the protein is also decreased. This results in muscle wasting and loss of lean body mass. Collectively, they results in symptoms that are rapid weight loss despite eating normally or excessively. Then there is polyphagia, asthenia, lack of energy due to depletion of both protein and fat store, and in severe cases, without treatment or insulin therapy, tissue wasting and severe tissue wasting and organ dysfunction can lead to death within weeks. Type 2 diabetes mellitus is caused primarily by the insulin resistance, that is the reduced tissue response to insulin. It is not by lack of the insulin production. It accounts for about 90 to 95% of all cases of the diabetes. It often develops at the age of or after the age of 30, but increasingly seen in younger people also due to rising obesity rate. The onset is gradual, often unnoticed uh, in the individual for years, and it is termed as adult onset diabetes. But increasingly, it is common in younger age group also. Obesity is a most important risk factor, especially central abdominal obesity, and there is a strong association with metabolic syndrome, that is obesity, hypertension, dyslipidemia, and resistance to insulin. Unlike type 1 diabetes, the insulin levels are often high in type 2 diabetes in early stages as the pancreas attempt to overcome the resistance of the insulin. Over time, these beta pancreatic cells, they exhaust and reduce the insulin secretion. And progression to diabetes begins with the resistance to insulin. There is compensatory hyperinsulinemia, and then there is beta cell dysfunction that lead to hyperglycemia. So excess adipose tissue, especially the visceral fat, release inflammatory mediators and adipokines that impair the signaling by the insulin, and high level of free fatty acid, they further worsen the insulin resistance. The metabolic effects of the insulin are reduced in type 2 diabetes mellitus due to development of resistance. So the target tissue, muscle, liver, and adipose tissue become less sensitive to the insulin, and due to these insulin less sensitivity, there is compensatory hyperinsulinemia due to increased secretion of the insulin by the beta cells of the pancreas. And this is gradual over time, and initially there is beta cell stress, and over time there is dysfunction of the beta cells. So possibly the carbohydrate utilization is impaired, leading to elevated blood glucose, and excess blood glucose will result in increased insulin secretion, creating a vicious cycle. So there will be decreased insulin receptors as well as abnormalities in the signaling pathway that are due to weight gain and obesity that results in lipid accumulation in tissue and muscle liver that are responsible for abnormalities of the signal pathway. As a result, the carbohydrate metabolism is impaired. So there are fewer insulin receptor and lipid accumulation in the target tissue, in the muscle, liver, and there is disruption of the disruption of the insulin signaling pathway. So there is a condition of chronic low-grade inflammation, and this is the process by which this compensatory hyperplasia occurs in the pancreas in type 2 diabetes mellitus. Metabolic syndrome is a cluster of disorder. There is central obesity, excess abdominal fat, there is resistance to insulin, there is fasting hyperglycemia, lipid abnormalities that are increased triglyceride and decreased HDL, and increased cholesterol. Also, there is hypertension. Collectively, these factors increase the risk of type 2 diabetes and cardiovascular diseases. So, atherosclerosis and vascular damage are major complications that are associated with this. Then, insulin resistance and associated metabolic changes, such as the lipid abnormalities, they accelerate the risk of cardiovascular disease. While obesity and visceral fat accumulation are the primary drivers of insulin resistance, several other conditions, both acquired and genetic, can impair the insulin signaling and predispose the individual to type 2 diabetes. One of these is polycystic ovarian syndrome that affects about 6% of the women during reproductive year, and it has got certain features. There is increased ovarian androgen production, and there is also marked insulin resistance. So there is hyperinsulinemia, that is elevated insulin level, exacerbates androgen production in the ovaries, and this results in cycle of insulin resistance and hormonal imbalance that is seen in about 80% of the women. Then there are some other long-term risks such as increased risk of type 2 diabetes, elevated blood lipids, that is dyslipidemia, and also cardiovascular diseases. Cushing syndrome is the result of excess secretion of glucocorticoids such as cortisol, and these glucocorticoids, they oppose insulin action, leading to hyperglycemia, that is elevated blood sugar, and reduced sensitivity to insulin in muscle and adipose tissue. There is also increased hepatic production of the glucose. So there is also acromegaly that is associated with insulin resistance. There is excessive secretion of growth hormone, and growth hormone is anti-insulin in nature. It decreases glucose uptake by the muscle and fat and stimulates lipolysis and increase free fatty acid that worsens the insulin resistance, and also promote the glucose overproduction by the liver. Then there are some genetic causes that can be reduce insulin receptor number or function, or they alter the post receptor signaling pathway or lead to severe insulin resistance even in lean individual. These genetic factors can overlap with conditions like familial obesity and metabolic syndrome, compounding the risk of diabetes and cardiovascular diseases. This is a list of factors that can cause insulin resistance and contribute to type 2 diabetes mellitus. The listed causes include both acquired and genetic conditions that impair insulin signaling or its action on target cell. The factors mentioned are obesity or overweight, especially with excess visceral weight, excess glucocorticoid as occurs in Cushing syndrome or steroid therapy, excess growth hormone, pregnancy and gestational diabetes, polycystic ovarian disease, lipodystrophy, either acquired or genetic, associated with accumulation of the fat in the liver, autoantibodies in the autoantibodies that are against the insulin receptor. Then there are mutation in the insulin receptor and mutation of the peroxisome proliferator activator receptor gamma, PPAR gamma. Then there are mutations that cause genetic obesity, such as melanocortin receptor mutations. Hemochromatosis is also one of the cause. So this hemochromatosis is a hereditary disease that cause iron buildup in the tissue. Here we have categorized the factors for the insulin resistance and type 2 diabetes. There are hormonal causes such as excessive glucocorticoids, excess growth hormone, or polycystic ovary disease. Then there are some genetic causes. There are mutations in the insulin receptor or PPAR mutations or genetic familial obesity, and there are other conditions that result in insulin resistance such as obesity, gestational diabetes, hemochromatosis. The prolonged insulin resistance, when it is severe and prolonged, it places a continuous demand on the pancreas to secrete high level of insulin to maintain blood glucose within a normal range. Over time, this excessive workload leads to beta cell dysfunction, or exhaustion, reducing their ability to produce adequate insulin. So this process occurs in stages. In the early stage of the compensated insulin resistance, the insulin resistance is there, but the beta pancreatic cell, they compensate by secreting high levels of insulin. Hyperinsulinemia occurs, and the blood glucose may remain near normal or show mild postprandial hyperglycemia after carbohydrate ingestion. Then there is intermediate state where the beta cell start to decline. There is continuous overproduction of the insulin, and this overproduction strains the beta cells. So in the postprandial state, the glucose level rises, leading to moderate hyperglycemia. Then in the late stage, the beta cell become exhausted or damaged, often due to lipid accumulation. Uh, there is oxidative stress or genetic predisposition. Insulin secretion is inadequate, and fasting hyperglycemia develops, leading to clinically significant diabetes. So some obese individual with insulin resistance, they never develop type 2 diabetes due to resilient pancreatic beta cells, while other progress to diabetes as their beta cell fail, often influenced by genetic and environmental factor. So this picture is summarizing this concept. There is progression of type 2 diabetes from insulin resistance to beta cell failure. There is early stage where the compensated insulin resistance is there. There is high insulin level, and mild hyperglycemia is there, and postprandial hyperglycemia is also there. Then there is decline in the beta cell, that is intermediate stage, and there is postprandial hyperglycemia, and later the beta cell failure result in fasting hyperglycemia. So the variable outcome is there due to resilience of beta cells. Some do not develop the disease, while some progress to diabetes mellitus. In the early stages of the type 2 diabetes, treatment often focuses on lifestyle modification rather than insulin therapy. Key approaches include exercise that improves insulin sensitivity, promotes glucose uptake in the muscle, and help reduce blood glucose level. There is also another measure is caloric restriction and weight reduction. So reducing body fat, especially visceral fat, significantly improve insulin sensitivity and may even reverse early type 2 diabetes. The drug treatment for the diabetes mellitus is first this thiazolidinediones are used, such as pioglitazone, and it increases the insulin sensitivity of the tissue, especially muscle and adipose tissue, to the insulin. Then in early diabetes, metformin can also be used. It suppresses glucose production in the liver and improves peripheral glucose utilization. Then sulfonylureas, for example, glyburide and glipizide, they stimulate the pancreas to release insulin. Then there are incretin-based therapies besides the replacement therapy for insulin. Uh, these incretin GLP-1 analogs are Flozin family members, and they enhance insulin secretion in response to meal and suppress glucagon and helping lower the blood glucose. And then DPP4 inhibitors such as sitagliptin, sexagliptin, linagliptin, and allogliptin, they block the enzyme that degrade this GLP-1 and GIP, prolonging their insulin stimulating effect. When lifestyle modification or oral medications are insufficient due to progressive dysfunction and loss of beta cells, then insulin replacement therapy is required to control the plasma glucose. This table compares the key features between type 1 and type 2 diabetes mellitus. The age of onset for type 1 diabetes mellitus is before 20 years of the age, so it is juvenile onset, while type 2 diabetes mellitus usually occur after 30 or 40 years of the age. So this is adult onset. Then in type 1, the body mass is low. The patient is usually wasted or have normal body mass, while type 2 patient most often they have got visceral obesity, means the fat is accumulated around the abdominal organs. The plasma insulin level for diabetes mellitus type 1 is low or absent due to destruction of the pancreatic beta cell, while in type 2 diabetes mellitus, the insulin levels are normal to high initially due to insulin resistance and compensatory hyperinsulinemia. The plasma glucagon level in type 1 can be high but can be suppressed. So the plasma glucagon level in type 2 is high and it is resistant to suppression. So the plasma glucose in both type 1 and type 2 is increased. Then there is hyperglycemia. The insulin sensitivity in type 1 is normal. The problem is deficiency of the insulin, not its resistance. While in type 2, the problem is the development of the insulin resistance. So the sensitivity is decreased. Then the therapy used for type 1 is from the start is insulin therapy, while the type 2 is managed by some life style changes, weight loss, and then thiazolidinediones, metformin, sulfonylurea, and insulin. Now, what is the physiology of diagnosis of diabetes mellitus? The diabetes mellitus relies on identifying abnormal glucose metabolism, typically through urine and blood tests. So urinary glucose is one of the tests. In healthy individual, urine contains undetectable amount of the glucose due to efficient reabsorption in the kidney. In diabetes mellitus, the excess glucose in the blood surpasses the renal threshold, and that is this renal threshold is about 180 milligram per 100 ml. That lead to spillage of the urine into the spillage of the glucose into the urine. The amount of the glucose in the urine correlates with the severity of the disease and carbohydrate intake, and the tests range from simple dipstick test to detailed laboratory measurement. Then fasting blood glucose is another test, and here the normal fasting level is about 80 to 90 milligram per 100 ml, and the upper limit of the normal is 110 milligram per 100 ml, and this uh, level more than 110 milligram per 100 ml suggests diabetes mellitus or marked insulin resistance. So fasting blood glucose is measured after an overnight fast of about 8 to 12 hours. Then plasma insulin level is another test, and in type 1 diabetes, plasma insulin is very low or absent both during fasting and after a meal due to beta cell destruction, while in type 2 diabetes, plasma insulin is elevated as a compensatory mechanism for insulin resistance and greater rise in insulin after a glucose load during glucose tolerance test. Normal level of this glucose is about 16 to 116 200 hour after the glucose administration. Glucose tolerance test is a key diagnostic test used to assess the body's ability to manage a sudden glucose load. It is especially useful for diabetes diagnosis and distinguishing between normal and abnormal glucose metabolism. So normal response is when a fasting person ingests 1 gram of glucose per kg of the body weight. The blood glucose rises to 190 to 100 milli, blood glucose 90 to 100 milligram, 90 milligram per 100 ml. Then uh, blood glucose return to normal or slightly below baseline within the 2 hours. The quick rise and fall indicate normal insulin secretion and normal insulin sensitivity. In diabetes mellitus, there is this fasting glucose that is more than 90 milligram per 100 ml. It excessively increases after the meal, and it takes about 4 to 6 hours to return to baseline and does not fall below the control value. So by measuring the plasma insulin level along with the GTT or glucose tolerance test, the type 1 and type 2 can be differentiated. In type 1 diabetes, the plasma insulin is very low or indetectable, while the type 2 diabetes plasma insulin is elevated, but there is insulin resistance. So this graph compares both the glucose level uh, over time between normal individual and person with diabetes mellitus after glucose ingestion. The red line, that is the normal curve, starts at the fasting blood sugar of 90 milligram per 100 ml, peak at about 120 to 130 milligram per 100 ml within first hour after glucose intake, and return to baseline in 2 hours. Within 2 hours, it returns to baseline. It indicates normal insulin response and efficient glucose uptake, while this green line is diabetic curve. Here, it starts at a higher level, 140 milligram per 100 ml, which is already above the normal threshold, and rises sharply to 200 milligram after ingestion of the glucose and decreases very slowly approaches pre-insulin level, approximately pre-ingestion level, and fails to touch this baseline, so indicating impaired glucose regulation due to lack of insulin. Type 1, or resistance to insulin, that is type 2. So this dashed line is the baseline. Acetone breath is significant clinical indicator of ketoacidosis, commonly associated with type 1 diabetes mellitus. So in severe diabetes, there is increased fat breakdown due to lack of insulin or severe insulin resistance. This results in excessive formation of ketone bodies or keto acids, acetoacetic acid, and beta hydroxybutyric acid. A portion of acetoacetic acid is converted into acetone, which is a volatile substance. Acetone vapor is exhaled, leading to the characteristic fruity or sweet smell of the breath. So in type 1 diabetes, the acetone breath is common due to high ketoacids production. And in type 2, ketoacids are not typically produced in early stage but can appear in severe cases with significant insulin resistance. Urine test can detect ketoacids or ketonuria, which help to evaluate the severity of diabetes and risk for diabetes ketoacidosis. The goal of the type 1 diabetes mellitus is to provide the insulin, and this insulin is given to restore the normal carbohydrate, fat, and protein metabolism as closely as possible. There is regular insulin. The duration of action is 3 to 8 hours, and it is given usually in the daytime, particularly at mealtime, to manage the postprandial blood glucose spikes. While there are other longest acting insulins also. The duration of action of these insulin is 10 to 48 hours, and it is administered once a day, and to provide the baseline glucose control throughout the day, and it is often combined with regular insulin at mealtime. So a single daily dose of long acting insulin maintains the basal metabolic balance. So additional insulin, this is also given around the mealtime to handle sudden increase in the blood glucose. These glucose are derived from animal pancreatic tissue, pigs or cows, and now the human insulin is also produced by recombinant DNA technology that is preferred. So advantage of this is the reduced risk of immune reaction or sensitization compared to animal insulin. While the type 2 diabetes mellitus, the main focus is initially on the lifestyle modification. That is the first line of the therapy. There is dieting, the caloric restriction, and balanced nutrition that are essential to reduce the body weight and improve the insulin sensitivity, and also recommendation for exercise for to increase the glucose uptake by the muscle independent of insulin and help reverse the insulin resistance. Then there is a pharmacological treatment. If the lifestyle changes are insufficient insulin sensitization drugs such as thiazolidinediones they are used, or metformin can be used that reduce hepatic glucose production and improve insulin sensitivity. Sulfonylureas stimulate pancreatic beta cell to release more insulin. Then, as we have discussed earlier, incretin-based drugs, GLP-1 mimetics or DPP-4 inhibitors, they also used to enhance secretion of the uh, insulin. And then finally, exogenous insulin can also be used in the later stages when pancreatic beta cell function declines and insulin injections are required to maintain the blood glucose level within normal limits. Diabetic patients are prone to atherosclerosis, arteriosclerosis, severe coronary diseases, and microcirculatory lesion due to hypertension that is common in diabetes, elevated circulating cholesterol, and lipids caused by abnormal fat metabolism. So, this is one of the reasons of early death in the uh, type 1 diabetes mellitus. So, current approach for this to encourage the patient to take or consume a normal carbohydrate diet with sufficient insulin administration to mobilize the carbohydrate. This approach reduces fat metabolism and lower the elevated cholesterol and lipid level, reducing the risk of the arterio and atherosclerosis. So complications like retinopathy, cataract, hypertension, kidney disease, and increased infection risk are closely tied to high blood glucose and lipid level. Lipid lowering drugs are also used, such as statin, and they reduce the cardiovascular risk and prevent these complications. Thank you for watching this video. If you have any query, please write in the comment box.